meeting
No
starts
problem.
at 8. I'm so sorry, sir.
No problem.
Yeah. Good evening, everyone. I figured I didn't wish you all.
That's
Good
okay.
evening, everyone. Good evening. So,
Good evening.
today is a very important day from IAP Allergy and Applied Immunology chapter. We all are discussing a lot on different forums about different stages of allergy, whether we are talking about atopic march, when we are talking about food allergy, it's a well saying that some of the foods allergy comes earlier and then it goes away faster. Some of the foods it comes later and stays. Many a times we speak that allergy is more a problem of childhood or adolescent or young adult, and as you are getting elderly, then allergy also get aged. So we thought that why not to discuss about this important phenomena, that how allergy itself, the concept of allergy, what is the journey of that? That means how it is starting, how it is aging with the age, whether it is getting more and more mature as the person is getting matured, or it is getting more and more older and ultimately phasing away. And what are the different factors? So I think this is a very important webinar, very unique webinar with a unique thought process. And I'm very thankful that for taking this challenge, Dr. Sunila Nayak, she is a senior allergy specialist, senior pediatrician from Bangalore. So she agreed to help us out in this webinar. So I would like to welcome ma'am, Dr. Sunila Nayak, and for her welcome remarks, and thereafter she will bail us through with her team of experts that how she wants to navigate the session. Ma'am, the stage is yours, please.
Thank you. Thank you, Dr. Neeraj. Thank you for asking us to um, discuss this very, very interesting and very unusual topic about allergy and age. So allergy is not a condition that's limited to childhood. It evolves with us, affected by our environment, immune system, lifestyle. And there's a lot that we don't know, and we know a little bit. So what we'll do, we'll go through this today. And to start us off, we have Dr. Mosam. Dr. Mosam Maru is a pediatrician and an allergist who is practicing in Mumbai. She has trained in allergy from different places in India, UK, US, and she's currently practicing in her own allergy asthma center in Thane. And she has also been awarded quite significantly for her work in allergy education, and is an active member of the multiple national and international allergy academies. Dr. Mosam, over to you.
Thank you so much, ma'am, for introduction. Good evening, everyone, the esteemed faculty and the audience who is listening. So my topic for today is growing up with allergies, what changes as we age. My name is Dr. Mosam Maru. I'm an allergy practitioner practicing in Mumbai and Thane. Now let us see why this topic is important. Allergies are not static, they evolve with age. What begins as food allergy or eczema in infancy may transform into asthma or allergic rhinitis in the school years, and later into persistent respiratory or even adult onset food allergies. The immune system is constantly changing, influenced by genetics, environment, and lifestyle factors, which means that the allergies always change the way they appear and also progress, and this shifts across the lifespan. Understanding these age-rated patterns not only helps us predict what's coming next for our patients, but also guides timely interventions. Through case-based discussions today, we'll explore how allergies grow up right along with our patients, sometimes resolving, sometimes persisting, and at times appearing for the very first time in adulthood. So the presentation starts with two cases of Aisha and Isha, but essentially through the cases, I will have a lot of questions in between that may or may not have answers in our minds. So let's begin with the first case, which is of Aisha. She's a 28-year-old married working woman hailing from Surat, currently residing in Mumbai, and soon to start a family. She's a known case of persistent allergic rhinitis for the past 3 years. For the very first time, when she met the allergy specialist, she got to know that she was sensitized to dust mites, molds, and pollens. She has well controlled symptoms and she has a good compliance to the treatment that she's been using currently. She follows up regularly with the allergy specialist. Currently, she's on a combination nasal spray and dust mite immunotherapy. She was born by a normal vaginal delivery, exclusively breastfed till 5 months of age, after which complementary feeding was started with various food items. She has no other comorbidities since childhood or no other allergies diagnosed by the physician. There's no family history of atopy. However, she gives a history that mother catches cold quite easily and quite often. She has a busy but a healthy lifestyle and also owns a pet dog for 2 years now. Now, let us summarize the case so far of Aisha. She has a well controlled respiratory allergy with no family history of atopy. She's born by a normal vaginal delivery and had good infant feeding practices. She has a healthy lifestyle and did not have allergic progression as per the allergic march that we all know about. If everything was right in Aisha's life, why did she go on to develop allergies later in life? Now let us learn a little bit about Aisha's mother. Aisha's mother is a 68-year-old woman and is a yoga practitioner residing in Mumbai. For one of the allergy specialist follow-ups, she accompanied Aisha. She had complaints like sneezing and congested nose and eye itching for the past 4 years, which was on and off, and it resolved with oral antihistamines. But every time she would stop these medications, the problems would recur. And she was really upset because she was not able to enjoy outdoors. On skin prick testing, she was sensitized to few pollens. She wants to now know if she can be given immunotherapy like Aisha. So the next question for the audience is, would we give immunotherapy to this patient, even though she's 68-year-old? The story now continues as Aisha goes on to have a baby. She's delivered a healthy baby by a cesarean section who is exclusively breastfed and has been initiated with complementary feeds at 6 months. She wants to ensure that the child doesn't get allergies like she did. And that is the reason she tries to keep the house clean all the time. Is maintaining hygiene a good preventive practice here? Is Aisha's intervention going to reduce the chance of the baby developing allergies on growing up? The story now continues where Aisha says that she consumes prawns routinely whenever she goes out or even cooks it at home without any symptoms. However, today she has visited the allergy specialist saying that she's experienced tingling in the mouth on consuming prawns. And on one of the previous occasions, she also had an itchy throat on consuming a dish which contained prawns. So the question here is, can food allergies begin in adulthood and still be severe or not? So far we have listened to Aisha's story and her relatives, and we had few questions. Now we will be moving on to the second case, which is of Isha. So Isha is also a 28-year-old working woman residing in Mumbai. She's married and is planning to start a family soon. She's a known case of persistent allergic rhinitis who was diagnosed 6 years ago by the allergy specialist. Her symptoms are partly controlled with oral antihistamines, and she is poorly compliant to the medications. She also has occasional flare-ups of nasal symptoms on and off in the past year. She has now revisited the allergy specialist, saying she's developed a new complaint since the past 4 to 5 months of coughing on exertion. Have Isha's allergies progressed after all these years? Now let us see a little bit about her childhood. She was born by a cesarean section and exclusively breastfed till 9 months of age, after which complementary feeding was started. At 1 year, she was also diagnosed with mild eczema, caramel protein allergy, and a reflux disease. However, she improved with the pediatrician's care. Between 2 to 5 years, she had recurrent wheezing episodes along with fever. These episodes subside by the time she started her primary school. After 5 years, she had intermittent cough and cold and used medications as and when required. However, she never felt completely relieved. She also suffers from weight gain and smokes occasionally with friends. She has a busy work-life routine, and that involves late working hours, and that is the reason she resorts to consume processed foods. Isha's father has a history of asthma and is currently on treatment, and her brother also has a history of shellfish allergy. Isha wants to know that if her child will also suffer from the allergies just like she did during her childhood. Now let us continue with this case. 12 months have passed, and Isha now feels better with the medications. She has delivered a healthy baby by a normal vaginal delivery. The baby is now 3 months old and is exclusively breastfed. Isha's baby is growing well, however, has dry skin but no other health issues, and emollients are being used for her dry skin after bathing. So let us summarize this case. Isha had an incomplete allergy care. She had all the allergies like how they're described in the allergic march and has few comorbidities. She also has a family history of atopy, has an allergy-prone lifestyle. She was delivered by cesarean section and had improper feeding practices during childhood. Is there anything Isha can do differently this time for her child?
Thank you. Thank you.
Okay.
Yeah, go on. Go on.
I'll go on. Okay. So now that both the cases are over, we don't have answers to our question, but we have more questions. Let us see these questions. The first question is the first 1,000 days of life critical window for reducing allergy risk? Second question is, at what age can we step in to reduce the risk of developing allergies? The third question is, which everyday exposures make us more prone to developing allergies? The fourth question is, how does the aging immune system
Dr. Mossam, I think
She's stuck somewhere.
somewhere connection issue or something.
The internet overreacted to her well-presented presentation.
Yeah, I think maybe some connectivity issue, I would imagine. But that was a very nice everyday problem that we all face in clinical practice, actually. And these are actual questions that patients ask us and parents ask us, whether it is the first time they're conceiving, whether it's their second child, they already have atopy. I think there was some internet issue, yes?
Yes,
Dr. Mossam?
yes.
Yeah,
Yes,
I think
I'm
the
so
final
sorry.
question we just needed.
Okay, I'll just open that. I'm so sorry for discontinuing the presentation like this. Okay, so the final question is, age, genes, or environment? Which one of this has a bigger role in allergy progression? Or whether it is age, genes, and environment, an amalgamation of all these three things which leads us to develop our allergies in our life. Thank you very much.
Thank you. Thanks, Dr. Mossam. That's very helpful because this is the kind of questions we always come across in clinical practice, and people ask this to us all the time. So I think it'll be nice to try and look through this and see if we can get some answers. We may not have all the answers, but at least some would be nice. Yeah, great.
Yes.
Thank you, Dr. Mosam.
Thank you
I
so
think
much, everyone.
we can move on to the next speaker, and I'd be very, I'm very happy to invite Dr. Kunal Chandwar, who's a very well acclaimed and highly awarded clinical immunologist and rheumatologist who is now also an allergist. And I'm very happy to have him join us to explain to us the complicated process of immunology in what he makes it, much more fun. So let's have a listen to what happens to the allergy or the allergic march as we age. Over to you, Dr. Kunal.
Thank you so much, ma'am. Thank you, Sunila ma'am and Neeraj sir, for the invitation. And I feel like the elephant in the room because amongst most allergists and uh, pediatricians, I'm the immunologist here, both figuratively and if you see my size, I'm more like an elephant. But I'm not so sure if I'm going to answer all the questions that Dr. Mosam asked or create newer questions for you to ponder upon. But let us discuss the immunology of allergy and if it can explain a lot of questions that bring about. So, we will discuss the allergy orchestra and how it is changed or challenged by the march of time. This is an immunologist's guide to why your body can't take an easy joke. So, how is our musical program for today? So we'll meet the players that are there in allergy. We'll understand how this orchestra learns to chill out. And we'll also see how age conducts the symphony. And in its golden years, how does allergy and its quirks beg well with each other? And the picture here is of, if you can understand, is from one of those uh, mystery movies where the player would hunt for a treasure, and once they capture the treasure everything starts to fall off, and something similar happens when you see a patient's allergy immunology going along. And how does it act? So it happens in multiple acts as we see. The first act is the act of a barrier breach, which leads to a lot of alarmins being secreted. And these alarmins call the innate lymphoid cells, so the first set of immune responses. This then actually leads to the invitation to the main cells for allergies. These are the Th2 allergen system and leads to production of the immunoglobulins. These immunoglobulins then ensure that the foot soldiers of allergies come and cause their changes, and then come the peacekeepers. So, like Avengers, they assemble once a system is broken. I'll start with a small joke. And the joke goes as, why do ants never get sick? Because they have little antibodies. I hope you had a nice laugh. So, what is allergy but a case of mistaken identity? The Th2 system that is much talked about is actually designed in your body to fight helminthic infections, and allergens are actually not very harmful to your immune system. But it is the Th2 system, like this shown in the figure, that instead of seeing or going with the helminths, starts seeing the allergens with much greater details, and this puts the immune system on fire where it should not have acted. A very interesting part of history of how we came to this Th1 Th2 pathway is that these two people, Dr. Robert and Dr. Tim, were both scientists working besides in parallel labs together. Dr. Robert was working on the IgE system and how it acts, whereas Dr. Tim was then working on T cell clones. So he identified that there were two typical kind of T cell clones that would produce different kinds of supernatant. And he lended these supernatants to his good friend Robert across the lab, and he found that there were some supernatants that actually led to increased amount of IgE production, whereas there were other supernatants that didn't do anything. These two supernatants were then called as T cell growth factor 1. that didn't lead to growth of IgE, and T cell growth factor 2 that actually increased the levels of IgE in the supernatant. So then came the nomenclature of how Th1 and Th2 was labeled. And what we find is that the Th1 or the type 1 immunity is more involved in our immune system and its functions to fight against pathological organisms, whereas the Th2 or type 2 immunity is more involved in the allergic reactions, in more anti-inflammation as compared to inflammation and the healing processes. The cell response is mainly regulated by certain regulators. For Th1, it is the interleukin 12, STAT4, and Tbet that are there. Whereas for the Th2 system, it is the interleukin 4, STAT6, and GATA3 axis. And once we come down to the genetics of allergies, you'll understand the importance of these oddly typed words and what they mean to us. These are cross-regulatory pathways. So if you have more Th1, you'll have less Th2. And if you have more Th2, you'll have less Th1. So what happens? So the first thing is usually the breakage of the epithelial barrier. So as soon as the epithelial barrier is broken, usually by allergens that are rich in proteases, that leads to easy breakages of these pathways. And this leads to some danger signals being announced. These are called as alarmins. And the major alarmins that we see in the allergy immunology pathways are the TSLPs, the IL-25s, and the IL-33. So if there's any breakage, they'll call for aid and the TH2 system will be there. So if you actually see the pathway, I can understand that these could be overbearing diagrams, but I'll try to make it simple. If you have any allergens that has proteases, these allergens will in turn break either the skin or the respiratory or the gut epithelium. And this in turn allows entry of the allergen inside. This in turn will lead to release of what are called as alarmins. This could be TSLP, this could be IL-33, this could be IL-25, and it starts what is called as the allergen process. Then comes the role of what is called as innate lymphocyte cell type 2. So these are the first responders to any allergic manifestation. They are innate counterpart to the Th2 system, and they are pre-wired to produce type 2 cytokines. These are present when the yolk sac is formed, and they don't need sensitization or the processes that usually happen in an allergic sensitization process, and hence can cause allergies even at the first presentation of an allergen. They don't need usually an antigen to be produced. These in turn release a lot of IL-5 and IL-13 that causes recruitment of both eosinophils and mast cells in the body. Then coming to the main cell. So once you have an allergen that is there, it is then identified as an antigen by the dendritic cells. These dendritic cells then go to the draining lymph nodes and present the antigen or allergen to a naive T cell. This naive T cell then, in the presence of the IL-4 that was initially secreted by the ILCs or the basophils, turns into an allergen-specific Th2 cell and produces its action. So this is how it goes about. You have all these allergens that could be there. There is disruption of the epithelial barrier. The ILC2 cells will then call the eosinophils and at the same time sensitize the dendritic cells to go to the marrow and go to the lymph nodes and activate the T cells into T regulatory cells. And these T regulatory cells will then bring about the Th2 pathway and progress, the allergic phenomenon will progress. Then these Th2 cells will further release cytokines. The major cytokines here are IL-4, IL-5, and IL-13. IL-4 is important for changing the production of IgM to IgE, which is the main immunoglobulin of allergy. Then IL-5 is again an important cytokine for production of our recruitment of eosinophils. And IL-13 is the pleiotropic master effector that causes a lot of pleiotropic allergic actions. Then come the foot soldiers. So the IgE that is now generated will bind to your mast cells and basophils, and as soon as the next allergen attack comes, they will degranulate, releasing a lot of preformed mediators like histamine and tryptase that cause various allergic symptoms. The eosinophil cells are more like your commandos who will go and directly attack into the tissues, causing tissue damage. A little bit about the IgE molecule. So this is a specific kind of antibody that we usually see only with anti-helminthic and allergic mediated immune phenomenons. So in presence of IL-4 and IL-13, what we do see is that there is a class switch from IgM to IgE, and there is also an affinity maturation that happens in the lymph nodes where you have very high affinity binding IgE antibody targeted to an antigen. And this leads to binding of these IgE to the Fc epsilon receptors on mast cells and basophils and eosinophils along with the B cells, and create a significant immune response once a allergen is encountered. Now, beyond, so we all knew that this was a Th2 pathway that was taught to us from our microbiology days to our allergy days. But beyond the Th2 pathway, we have a lot of newer understanding of what cells are there in the immune cascade. So the Th9 cells are the amplifiers of allergy. They don't directly initiate an allergic reaction, but they release multiple cytokines that in turn activate mast cells, eosinophils, promote another set of allergic reaction, including mucus production and airway hyperresponsiveness. So they have a lot of plethora of manifestations: increase eosinophils, mast cells, Th2, Th17 pathways, increase the amount of ILC2s and their actions, mucus hypersecretions, and airway epithelial actions. Then there are the Th22 cells. Now, these cells are very important for patients who have atopic skin disorders. These cause, so they are involved in the skin generation and regeneration and hyperplasias, and in dysfunctional or inflammatory reactions of the Th22 cells will lead to uh, leaky barriers in the skin and contribute to the vicious cycle that brings about atopic dermatitis. So they have a role in creating antimicrobial peptides, keratinocyte proliferation, their differentiation, and their remodeling. And their inflammation is usually significantly involved in most autoimmune or allergic skin conditions. Then there are, so you would think that the type 1 immunity is classically anti-allergic, but there is a type of type 2 cytotoxic T cells that are part of the type 1 immunity that also act as potential allergens. And their function is to stop making interferon gamma and instead produce type 2 cytokines. And they contribute directly to eosinophilia and airway inflammation. And these cells are often quite resistant to corticosteroids, and hence in those patients where difficult to treat asthma is encountered, in biopsies you might often find these kind of cytotoxic T cells. So we have with age and with expertise identified that even the cytotoxic T cells, like the helper T cells, further show plasticity, and they transform into different types, including type 2, type 9, type 22, and type 17. And all of these cells could be involved in the allergy cascade pathway. The another important cell that is there is called as the type 17 cell or Th17 cell, and this is often called as the type 3 immunity, where you have recruitment of the neutrophils. So this is the classical neutrophilic asthma that is often difficult to manage, which is caused by the Th17 pathway. And here, because of chronic inflammation, the Th17 pathway gets activated, and this leads to recruitment of both the innate lymphoid cells 3 and the Th17 pathway. A lot of neutrophil comes. You have netosis, where the extracellular extrusion of the nuclear material happens in the neutrophils and damage ensues. So in summarizing, you have an allergen that is then primarily identified by a dendritic cell. The ILCs will start acting as soon as the danger signals are brought about. This will then go into the lymph node, and you will have specialized B cells that will release IgE. This IgE then will bind to the mast cells, the eosinophils, and cause their degranulation. And at the same time, the type 2 cytokines will activate all the mediators of allergy. So this was how the allergy orchestra happens inside the body when an allergen is there. There are a lot of genes and receptors that are important. So in the whole genomic blueprint, once it was printed for the patients who had a lot of allergies, we were found that certain patients were born a certain way and they had cytokine genes that were overexpressed. These included IL-4, 5, 13, and 33. And you could understand from the discussions priorly how these genes or cytokine genes are important. Even the IL-33 receptor genes were implicated. Genes including the STAT6 and the GATA3 gene that were very important for Th2 pathway to get activated again are transcription factors that are necessary. A very common example that we see is Wiskott-Aldrich syndrome. So what happens in Wiskott-Aldrich syndrome is a mutation of the VASP gene. Now, the VASP gene in its time is a very potent negative actor on the GATA3. So once the VASP gene goes off, as in Wiskott-Aldrich syndrome, your GATA3 activation becomes very high. And in turn, you have all of those allergic manifestations that you see. So similarly, you have a lot of autoimmune or primary immune deficiency disorders where you can have one or the other genes that are there in these regulatory pathways go on or off, and hence you could have a lot of allergic manifestations. Sometimes you might have even minor changes in these gene expressions and things might be different. Another very interesting aspect of the allergy genome is that most of, or the most important of the allergy cytokine mediators lie on the same chromosome. So IL-3, IL-4, IL-5, IL-13, and GM-CSF are all on the 5q31.1 chromosome. And why is it important? Because we do understand that there's something called as epigenetics. And what does epigenetics do? It causes either transactivation or transrepression of a chromosomal gene expression based on what environment they get. So there is a multi-hit model of allergic diseases, why an allergic disease might happen at a certain time. So in a genetically predisposed individual, so the first hit is that you have a genetically predisposed individual. He has certain genes that are more likely to cause him allergy. And then there are multiple environmental or epigenetic factors that change or program his immune system's response. We also have seen over the years and identified certain somatic mutations that occur over the age as a person grows. And then there are acute triggers such as the allergen exposure or acute stresses that push the system over the clinical threshold. So, if you do remember the movie Ocean's 11, everything had to go all right for the heist to happen. Here, everything precisely has to go wrong in the right sequence for the heist to happen. And this is a very simple diagram. You need to have the right genetics first to have to start the allergic process. Then you need to have the right epigenetic mechanisms, the dysfunctions to start, the microbiome to alter, and then there are the other environmental factors, including vitamin D deficiency, your prenatal exposures to antibiotics, to allergens, to pollution, and overall diet and allergen exposure that decides how you have an allergy. So regarding somatic mutations, so us immunologists are very happy because these mutations are rarer and difficult to identify and keeps us on our jobs. Over the years, we have identified multiple somatic mutations like those as seen in something called as Vexas syndrome or DADA2 deficiency or so on. And even in allergy, so as you grow old, your immune system or your genetic system is exposed to a lot of insults. It has its own mechanisms to correct those insults. Sometimes it doesn't, and these leads to certain somatic mutations. These are not germline, and hence might explain that why some people might have very severe allergic manifestations at their later age. And we do understand, or I have identified certain mutations in the allergy pathway also. So what we have seen is that there is a KIT gene or a c-KIT gene that is very important for mast cell maturation and activation. And you can have gain of function mutation in this, and hence systemic mastocytosis might start very late in their uh, age in a lot of patients. Same way, there's something called as a STAT5B gene mutation that can cause mutations and result in a syndrome that is very similar to atopic dermatitis with severe eczema, eosinophilia, urticaria that can strongly mimic very severe atopic disease. So, if someone is presenting to you with very severe atopic manifestations at a very late stage of life, possibly you can think of a possible somatic mutation. Now, how does stress play a role or environment play a role in all of this? So, we do all know about the hygiene hypothesis and how limited microbial exposure might hinder immune training. And hence, once you get exposed to this, the immune system thinks that this is a new allergen and they start acting against it. Same way, pollutants cause significant oxidative stress and interfere with the activity of the epigenetic enzymes. And polycyclic aromatic hydrocarbons are linked to suppression of the type 1 immune system or the interferon gene promoter region and can lead or shift the immune system to a more type 2 pathway. Same way, prenatal diet with vitamin B12, folic acid, and even vitamin D has been shown to have correlation with how the immune system is processed. We have understood that environment plays a significant role in the rise of allergies. You have barrier damaging agents such as detergents, chemicals that damage the epithelial tight junctions. You have climate changes with longer pollen seasons, increased pollen production, and thunderstorm asthma that happen where you have large amount of allergen exposure, and even those with mild asthma can have severe reactions. And pollutants also change the way allergens are there, and they change their character, making them more allergenic. And the role of stress. So once there is a significant stress, let's say an infection or a surgery or significant psychological stress also, your body releases cortisol, and this cortisol again changes the pathway from a Th1 to a more Th2 pathway. And hence you can, after an episode of acute stress, start developing newer allergic manifestations. Neurogenic inflammation can happen. So, in response to stress, sensory nerve endings in the skin and airways release neuropeptides. These neuropeptides, especially like like substance P, can directly activate independent of the Ig, the mast cells, and the basophils. And this is again an important reason why acute stress can cause severe urticarias. Apart from severe urticarias, they can even start newer allergies because the cytokines that are there important for allergies will get into the system. So we have seen that patients after major surgery or severe infections can mask or unmask a latent allergy, and even vaccination can start a physiological stress or a psychological stress to create an allergic reaction. There's also something called as immunization stress related response that can often mimic. This is a neuroimmune mechanism where you have dizziness, throat tightness, and can mimic actually a severe allergic reaction in these patients. So all of this has happened. You have developed allergies, and now comes the peacekeeping mechanisms. So you have regulatory mechanisms in your body, and this is one of the reasons why even if you have allergy, it goes or improves on its own with time. A lot of patients or their parents would come and say that our allergies were very severe when we were children and now they're much better or have not been bothering us for long. And this is because of this peacekeeping mechanisms, the regulatory mechanisms that we have. So the T regulatory cells act nearly on every cell that is there in the allergy cascade. They reduce the Th2 cells, they suppress mast cells, basophils, and eosinophils. They induce much more other tolerogenic dendritic cells and tolerogenic B cells that are there, and even suppress other cells like the Th1 and Th17 cells in the function. Only and only if there's a failure of the regulatory mechanisms will you actually see a severe allergic reaction. So normally you will have the Th2 cells that are produced if there is type 2 inflammation, but you can even have regulatory dendritic cells and regulatory Treg cells that can produce increased amount of regulation in this system. You also have something called as the IgG4 antibodies, and uh, what these antibodies do. So the Treg cells, if you have seen this movie, you would recognize that Jaya Bachchan comes here and tells Amitabh Bachchan that enough has been done and now you can stop dancing with the beautiful lady and come and dance with me. And Shah Rukh Khan comes and takes the beautiful lady to dance with him. So this is what Tregs do. They come and tell the IGs that you have had enough fun with the allergy cascade now, and let the IgG4 come and bind to the mast cells and cause immunosuppression. So IgG4 are basically blocking antibodies. They don't directly cause anything. They will go and bind to the same allergens as IgE and often to the same receptors and prevent activation of the allergy cascade. Then comes, there are even macrophages are of two types. There are the pro-inflammatory macrophages and the anti-inflammatory macrophages, the M2 macrophages. So if there is a more regulatory phenotype, in itself, both IL-4 and IL-13 will lead to these M2 macrophages being produced. And this in turn will release a lot of TGF beta and IL-10 that has a role in immunoregulation. And hence, this is the basic mechanism, the function of the T regulatory cells through which how our allergen immunotherapy acts. Even the body's own immune mechanism of desensitization with time acts through the same way. You have induction of allergen specific T regulatory cells. You have suppression of the Th2 cells. You have increased production of IgG4 cells. And for a long time, we have been trying to measure how IgG4 changes with allergen immunotherapy, along with desensitization of the effector cells, because with chronic exposure, they become less and less reactive to an allergen. So this is how the entire process starts. You have a dendritic cell that will then induce a T regulatory cell, and then it will send across negative signals. You can see the red signals going everywhere. It then inhibits the B cell functions, the dendritic cell functions, the T cell functions. The all other Th9, 22, 17, 1 are also suppressed along with the effector cell immunosuppression. What we've also found over our years of research is also that there is a cell called as a Th2A cell. And in our search for finding a immunomarker of how severe an allergy is, this Th2 cell helps. So the more active your allergy will be, the higher the Th2A levels are. And we found that with immunotherapy, they often go hand in hand with the response of the patient in its clinical sense. So probably better than what we have right now with IgG4, the Th2A cell levels might replace our biomarker armamentarium in turning allergies. Now coming to how age affects allergies. So when you're born, you are coming from your mother's womb and your mother is filled with foreign antigens. Hence, your immune system is designed to accept any and every foreign antigen that comes from your mother. Hence, you need a lot more anti-inflammatory pathway. Since we know that Th2 is primarily anti-inflammatory, you have a much higher Th2 as compared to Th1 in the initial years of life. And this actually increases your susceptibility to allergies. You also have a much naive thymus, and hence antigen presentation to the thymus is much higher. Hence, the sensitization is much higher when you are younger. As you grow old, your Th1 pathway tries to cover up to the Th2 pathway, and hence in from adolescent to adulthood is where your immune system reaches its peak, including the B cell activity, the T cell activity, and the Th2 cell activity. Pregnancy, you have much higher Th2 as compared to Th1. And as you age progressively, you have something called as immunosenescence. So this is, I think, what we have been taught and taught again. You have the atopic march. You have initially the skin, that is a very important barrier that is broken, and this leads to entry of a lot of allergens. You start having food allergies, then you start having aero allergies, and progressively these increase. The aero allergies, such as rhinitis, usually peaks in adulthood or in adolescence, and then we go along. I think Dr. Sunila is going to take much more details of how age changes the clinical features of allergies. And immunity in infancy, as I said, is significantly Th2 skewed. ILCs, as I did talk about, are present from birth, and hence, uh, from fetal hematopoiesis, they are already there to cause a type 2 response. The Th2 cells develop postnatally, and hence they are there to respond to whatever environmental exposure you might receive. And probably that is the reason why the hygiene hypothesis is gaining that degree of importance. The later you introduce an allergen, the more chances of its allergenicity increasing in the body stays. There is a midline peak. It is because you have a Th1, Th2 balance that is clearly tipped towards the Th2 in the atopic individuals, but the regulatory networks are still robust. And in elderly age, like fine wine, your allergies don't just get older, they get weirder. And if you remember, this movie is about all retired spies who can create a havoc, and so can our immune system. And there are two specific mechanisms that go hand in hand. One is called as immunosenescence. Your thymus is shrinking, it is involuting, and hence the antigen presentation is not as robust, or sensitization of both the regulatory and the activatory T cells is not as robust as probably in your adulthood. Your internal organs like the spleen and the skin also get impaired. Your mucosa is not as strong a barrier as you would want. And both the innate system and the adaptive system show their senescence features. Along with this, you have also some low grade boring inflammation that goes along, and this is called as inflammaging. And this correlation, or the balance between both the immunosenescence and the inflammaging, decides how a person is going to respond to an antigen. So the major cells that are there, including the macrophages, the B cells, the NK cells, and the T cells, you will find that you have more memory cells, but their effect is much more weaker. Your innate cells are also much more weaker in phagocytosis, in creating a damage and creating an effect that would create a very strong inflammatory reaction to stuff. This again is a very important reason why you have a lot of cancers in old age, because your immune surveillance system is much more weaker as compared to what you would have in your younger age. And that is why a lot of cancer immunotherapies involve strengthening your immune system and can have all those immune side effects. And what happens to allergy specifically? So you have your Th1 to Th2 balance that strongly shifts towards a Th2 profile. This creates an environment that is much more permissive to allergic inflammation. The allergen specific Ig decline with age, whereas the total serum Ig increases as you grow older. What is very important is mast cell numbers. So the mast cell numbers increase in density, and so do their functions. So their degranulation usually increases, and both the number and function increase actually leads to much severe anaphylactic reactions. So as compared to a young having an anaphylaxis, an elderly having an anaphylaxis is much more likely to have a severe reaction, or not to have a very favorable reaction to it. And hence, what we've also observed is a lot of food allergies that happen lead to much more severe reactions in the elderly as compared to the younger ones. And the eosinophilic functions and degranulations are reduced as compared to what a young person might have. So, to recap, allergy is a disease of dysregulated type 2 immunity, the ancient pathway that is repurposed against harmless environmental antigens. The cascade is initiated by an epithelial barrier damage that releases alarmins, and activates the very important innate lymphocyte cells, which are type 2. The adaptive immunity follows with the priming of Th2 cells that orchestrate the response via IL-4, IL-5, and IL-13, and lead to the production of IgE that binds to the mast cells and the eosinophils and cause damage. You also have cells like the Th9, the Th17, the Th2, and the Th22 cells that have some role, and tolerance through T regulatory cells and IgG4 antibodies are important, often harnessed in immunotherapy. And the journey through life profoundly alters the disease with the geriatric allergy paradox. You have immunosenescence and inflammaging working hand in hand. And here I come to an end to my presentation. Thank you so very much to the patient listening. I hope your concepts regarding allergy immunology were much more clearer, and I answered more questions than I raised one. Thank you.
Thank you. Thank you, Kunal. That was actually very interesting, an intriguing topic, very tough topic. And thank you for trying to make it so much more, palatable for us with all those little jokes as well, but also to make it more, relatable. Thank you. It was very nice listening to you and lots of learning for all of us, I'm sure. You did answer quite a few questions actually on the way. A lot of questions that Dr. Mosam has asked, you have answered there on the way. Now, I think we can move on. Thank you very much, Dr. Kunal, once again. Thanks for accepting the invitation to talk today.
Thank you so much, ma'am.
Thank you. We can now move on to the next part of this webinar, which is looking at the clinical aspects of exactly this allergy and aging, and how does it affect us in actual practical life. When you see a patient, how do we go about it, and what are those things that you have to keep in mind or take into consideration when you take this further. Right. Can you see my presentation?
Not till now, ma'am.
No. No? Can you see it?
Yes, it's visible.
Yeah, okay. Right. So, is it slideshow?
It's there, ma'am.
Yeah, okay. So, what are we looking at? So, now that we know how the immunopathology occurs, what's actually going on at a molecular level, and what happens when there's exposure to multiple things over time, and we now see what actually translates into in practical or clinical life. And so we are going to look at any patterns that we can recognize, the progression, and also the prognosis of allergy over time at different ages. So what is it that makes a genetically susceptible individual to have an allergy? What is it that makes you more likely to have an allergy? Dr. Kunal has gone through this in a molecular level very nicely, but to look at it in a broader term, is it age or is it environment? What is it? I think we now know that both are very closely related to this, and they're both closely linked too. The longer you live, the longer you are exposed to the triggers that can cause you problems. And in a susceptible individual, that might mean that you become sensitized. Now, being sensitized, is that enough? No. Till you have clinical symptoms, it is not an issue. But going from sensitization to clinical symptoms also needs time. And sometimes, as we have seen, even in a non-atopic individual, the chance, by chance exposure to something which is an external trigger, or something like stress or an infection, may just suddenly switch on this whole process, and that might increase your predilection to atopy. And one of the things that we saw doing this quite significantly in the recent years is COVID. And you know, a lot of people who were completely fine, had no symptoms of atopy at all, and post-COVID started having many symptoms, or some at least. So we all know the atopic march, and we know that we talk from right from infancy right into adulthood, different allergic conditions that can go on. I think it is time for us to include another group of individuals in our atopic march, which doesn't end at adulthood, but it goes on to the older adults or the elderly. This is very important as in the current demographics, people are living longer and many of them much fitter than we were expecting them to be before at a age which is 65 or 70 plus. And a lot of them are presenting with allergy-like symptoms, and it is quite important we know how to differentiate what is and what is not allergy and what is our approach to their treatment. We all know that through age, allergy changes. So at birth, you're the first thing that happens if you are susceptible and you are developing allergy. The commonest allergies that we see in the infant is the atopic dermatitis and food allergy. This then goes on as the child grows older, gets exposed to pollen, dust, or dust mites, or even pollution. They start developing respiratory allergies. And there at school age, you will start seeing that the asthma becomes more of an issue, which then, as it is, we all know it is a one airway, one disease, which then progresses on and combines with allergic rhinitis. And after about adolescence into adulthood, allergic rhinitis becomes the most prevalent allergy around. Having said that, if you see, the other allergies have not disappeared or become zero. Many of them, in some individuals, do persist, and in some, they can actually start only in adult life. So the peak age of atopic disease, it is adolescence and a young adult. And the peak allergic conditions that we see there, allergic rhinitis, asthma, and new onset food allergy. Having said that, we know roughly most of the time, because this is the common things that we see, we know how to deal with these. What we are not very, very sure about or would like more information about is the extremes of age. And that too, in the older adults, what are we going to do? How are we going to approach? The young infants and toddlers also pose quite a lot of challenges, but there are far more studies in the younger group than in the older, because allergy has always thought to be a disease of the young and a child. So whatever it is, it has to be taken into account, and the management of any disease, including an allergy disease, is completely tailored based on the individual, their age, their history, and of course, their comorbidities. The most important thing to remember, there is no one size fits all, and neither is the treatment. Let me take you through a few allergic conditions at different ages. We know that the first allergy that surfaces in most susceptible allergic individuals is dry skin. And if it is severe, we call it atopic dermatitis. And it stands out as the predominant chronic inflammatory skin condition across the ages. It is a recurrent and chronically relapsing and remitting with lesions which are quite eczematous and cause severe itching. And this significantly impairs quality of life. In infancy, where it is called early onset atopic dermatitis, and in childhood, this is the most common kind that you see, with 60% of them having problems before the age of 1 and 90% by the age of 5. They have a typical distribution as you see in the picture, and they are red, itchy, flaky patches and respond quite nicely if treated well with emollients and the basic treatment. However, they also all resolve, most of them anyway, or at least 60% of them resolve by 12 years of age, and some of them do persist into adolescence and adulthood. Quite often, this is also seen as an indicator for what is to come, or as the heralding atopy, which brings on the atopic march. So this also tells you to keep an eye on this child and make sure that you catch the other allergies or atopic conditions early and treat it adequately. As we go on to adolescence or adulthood, if there is a new onset at that point, you will see, even the persistent ones, you will see that the pattern changes. The pattern now moves on to more as shown in the pictures here, but they can also have localized variants. They can have chronic hand eczema. Lichenification becomes more of an issue. Though here the allergy and the atopic condition is still one of the key important triggers, the other triggers come into play. Most of it, and quite important and quite hard to treat, are the mental health conditions like stress, anxiety, and depression. And you see this a lot in the age group that we are discussing, which is from adolescence to adulthood, which again has a combination treatment. So you can't just treat the allergy, you need to look at the other stuff too. And then we come to the elderly. Elderly do also have atopic dermatitis, and this is a distinct subtype, usually not discussed so much in our regular allergic talks, because atopic dermatitis, as I said, is considered more of an infant or a childhood problem. Presentation in the elderly is different. The areas that are affected are different, and they have specific classic signs which are again not seen in younger adults or infants, which is this what they call as the reverse sign. As you see here, there is an area which is completely spared and surrounded by lichenification around. So that is called the reverse sign, and this is typical of elderly atopic dermatitis. Here again, the mechanism of atopic dermatitis is complex, as is how you would approach it for treatment. There may be a lot of comorbidities which might limit treatment options, and also you have to take into account age-related changes in the skin. Having said all of this, there is a lot of, there are key differences in both the classic infant atopic dermatitis and the adult atopic dermatitis. But when you actually start treatment, you don't need to worry. You can start treatment for everybody with your same basic treatment in any atopic dermatitis, which is moisturizing, emollients, and if required, treating the flare-ups with, as required, anti-flare-up medication. Wherever you're applying these other rules, you also take into account their comorbidities, you take into account their skin texture, and also add in some more as appropriate to that particular patient. So you tailor it to them, but your baseline will still continue to remain same. Now coming to the second most common allergy in infancy and childhood, which is food allergy. Food allergy. What is food allergy? The default mechanism for food, which is anything that you ingest, is oral tolerance. When this mechanism is disrupted or interrupted, you get a food allergy. So the inability to develop tolerance to a food is called food allergy. This can be IgE mediated or non-IgE mediated. You can actually develop a food allergy at any age, and when we look through it, there are similarities which are found in the etiology of development of new food allergies. I just wanted to mention that there's a very good article. It's a review article in the Journal of Allergy and Clinical Immunology, which takes you through the entire journey of food allergy from infancy through to adulthood, which is a very good read if anybody is interested. So quite often we get asked why and how. Why are they allergic to food? Many parents ask this about their children, saying, we are not allergic to any of this. Why is my child allergic to this? Or a lot of people ask, I never had any problem till now. How come I have now become allergic to something which I've had all my life till about 40 or 30 or whatever the age they have developed it? As we have already discussed, it is the inability to tolerate food or inability to develop oral tolerance to food is called food allergy. In a child or an infant, this is the inability. In somebody who is already eating the food and is fine, it is thought to be because of breach of tolerance. Now, there's a lot of research going on about this particular mechanism to understand why there is new onset of food allergies. And this is one of the hypotheses that is proposed. And that is at a certain point, for whatever the trigger might be, there is increased permeability or breach of tolerance in the gut for certain foods, and that actually triggers the development of a new onset food allergy. That is for ingested food. What about the non-ingestion pathways? Non-ingestion pathways are also quite common, and the one that we are all aware of and we, is oft talked about is the sensitization via skin or cutaneous sensitization leading to food allergy. We talk about this quite a lot when we are discussing atopic dermatitis and food allergy in infancy. But this can happen at any age. It doesn't have to be in infancy. There are other ways of sensitization, which is the inhalational one, where you see that if you're allergic to one thing and there is a homologous protein in something which is in food, then you might develop a food allergy for that later on in life. One of the examples for this is dust mite. Say if you are allergic to the tropomyosin in the dust mite, and then later on go on to develop the same allergy to the tropomyosin in the shellfish, which is a common protein in both of those. That is one way that this food allergy could happen, and this is an inhalational sensitization. Same thing happens with pollen, where you have pollen food allergy syndrome, where there are homologous protein between pollen and food, and that leads to the sensitization in that particular person, and that again can later on lead to allergy. Occupational food allergy is very common in people who work around food all the time. They too inhale very small microscopic amounts of food, but it's going on for a long time. You can see this in bakers who maybe are exposed to wheat flour or eggs, or even workers who work in this with seafood. They too can get exposed and hence develop allergy to that particular food. The other non-ingested way of developing food allergy is via a tick bite. Now, this is a rare condition, but has gained more awareness and has been in the news more recently. And that is the tick bite leading to the alpha-gal syndrome, where a person who's not allergic is bitten by a tick, which then converts the digestion process of a certain carbohydrate, which leads to a non-Ig mediated allergy, which occurs about 4 to 6 hours after ingestion of mammalian red meat in that particular person. So this is also a new onset allergy and can be seen in adults. So coming to the different ages of allergy, in infants, I think is the commonest for food allergy. Almost 8% of under 5s have been reported as having some sort of a food allergy. Thankfully, most of them do outgrow this. And the commonest food that children or infants are allergic to is milk, followed by eggs. Often, eczema precedes the development of food allergy. And that is what we were discussing in the atopic march. There are two unique allergy types in this age. One is called food protein-induced enterocolitis syndrome, or FPIES. Here, an otherwise well child is fed a particular food, usually either milk or eggs or cereals, and suddenly within within few minutes to 4 hours of having this, the child can become severely lethargic, have very bad diarrhea, vomiting, and almost look septic, and quite often is treated as sepsis or gastroenteritis. This thankfully does resolve in infants. If they have it, it does resolve by, by the end of infancy or early in toddlerhood. And the other one that occurs is the food protein-induced allergic proctocolitis, wherein in an otherwise well child, you have blood or mucus in the stool. Again, resolves by late infancy or early toddlerhood. So both these are very specific to the infant or young children. Once the child starts going to school, there may be some who are still outgrowing their milk or egg allergy, which is going on. But there are many other children who develop specific allergies, and these are allergy to peanuts or tree nuts. And unfortunately, these are the kind of allergies that persist, and quite a few of them can go on to develop anaphylaxis on exposure to these particular foods. So here, it is not only about the allergy and the diagnosis and finding out and telling them to avoid, it is also counseling. Because here the responsibility can be shifted or shared where in infants, that's mainly the parents or the primary caregivers who are making sure that the child is not exposed. Here, the children themselves have to start taking some responsibility. Their secondary caregivers or school or when social situations, there have to be that responsibility taken on, and that requires a lot of counseling, planning, and having a plan such that no matter what the situation is, people know what to do. This is a very important part of treatment and is also quite age specific. We then go on to even more riskier time in childhood, which is the adolescence. Here, it is the innate sort of the tendency of teenagers to rebel and also to try and fit in. There may be a lot of social pressure, and hence they may or may not want to carry their allergy medicine or their auto injectors. So they are much more, higher risk takers, and hence at a higher risk for fatal anaphylaxis. They are usually, it is a continued persistence of allergies such as peanut, tree nuts, and shellfish. Some of them do continue to outgrow milk or egg, but they are not the serious ones because they are usually not the ones who end up in anaphylaxis. But the ones they do, they cause a lot of anxiety to themselves and their parents, and there's a lot of social pressure to this group of people to fit in. The way we can help here is maybe having a separate consultation with the adolescent or the young adult, trying to impress upon them what is the way to go about it, such that they still get to do whatever they want to do, but are careful and take proper, adequate, precautions. And this is very important plan of their treatment. Then we come to adults. Less talked about, less known, but 50% of adult food allergies are those people who already had food allergies in their childhood and that has persisted, but 50% is new onset. And this can be to seafood like fish and shellfish, fruits and vegetables. There are more allergy types in adults than there are in children. So you can have things like oral allergy syndrome, pollen food allergy syndrome, even food-dependent exercise-induced anaphylaxis, alpha-gal that we just talked about, or occupational food allergy. Depending on what it is and what the type is, you would need to go down that specific pathway for whether it is investigation and then counsel based on what is found. So really, age and food allergy have quite a significant relationship, and it is very important to know this while you are investigation or when you are taking history or going through anybody who presents to you with a possible food allergy. The one condition which I have not gone through separately is the eosinophilic esophagitis, which is an emerging disease. And this can start right from very young children. And they can just present with symptoms of reflux and heartburn, dysphagia, and they might have poor growth or faltering growth. And this is very important to actually take it seriously, do the right referrals, get a gastroenterologist involved, because they can have persistent problems and it will need to be a shared care with the specialist like a gastroenterologist. We now come to the respiratory allergies. I will not be spending too long on this because these are the most common ones in adulthood, and we do know quite a bit, and these are what you would normally diagnose and treat as allergies. But we will go through what age has got to do with each of these in a very short way. And asthma, as we know, has a lot of different phenotypes. There are a lot of triggers, and they are different at different ages. So if we quickly go through the age-related different phenotypes of asthma, in the very young, the 0 to 12, allergic phenotype is the commonest one, and most of them do develop their symptoms by the age of 6, more in boys than in girls. Diagnosis is a little bit tough initially because when they're very young, they're confounded by other viral infections, viral-induced wheeze, and viral triggers which always seem to keep giving them wheeze. However, once they're about 3 or 4, it is easier because you can then have objective assessment too these days with the FOT in the picture and a PFT for later on. But it doesn't have to be with that. It can still be a clinical diagnosis. treatment with the MDI and spacer with the intranasal steroids. If done well, the response is usually very good. And alongside this, you should actually also look for the sensitization pattern, find out what the child is sensitized to, and where possible, if appropriate, commence immunotherapy if it is necessary. Once you do all this and with adequate treatment, many of them go into remission and all is great. The same thing when you come to adolescence. Again, it is still allergic predominance, but here girls are more affected than boys. But other problems start creeping in. Smoking, vaping, other lifestyle changes which can affect their asthma can come in. The diagnosis is both clinical as well as objective because these children are able to do their pulmonary function tests. Problem is the compliance with treatment. Again, it is a more risk-taking behavior, and because of which they have more severe exacerbations, and due to that, they have a much higher mortality. However, if you can build a rapport with this young adult, and if you can get across and get it through to them the importance of taking medication regularly, if possible, again, identify the culprit with if it is allergy, and if you can treat with immunotherapy, they will actually have something positive to look forward to, and hence you may have a much better outcome than if you just ask them to take medicines all the time. Then we come to adults. Here it all changes. There's a lot of new onset cases in adults, females more than males, and it is quite heterogeneous in etiology. They still have a significant number of allergic asthma, but it is not all allergic asthma. They also have other comorbidities quite significantly affecting their respiratory symptoms by this time, which could be allergic rhinitis, chronic rhinosinusitis, obesity, reflux, or even hormonal changes. So here, a careful and accurate clinical evaluation to recognize the correct phenotype is very important. And if you do that and then treat them well, they can have a very good response, especially if they're allergic and you have diagnosed it and treated them with the correct avoidance and intranasal steroid with an appropriate immunotherapy where indicated. Even if the immunotherapy is not indicated or not possible, if there is good avoidance and it is followed very well, they can have a good outcome. But most of the other phenotypes can have a persistent asthma and may need the involvement of a pulmonologist too. Older adults, older than 65, the incidence or the prevalence is quite high because here there are those which have persisted either from childhood or adulthood. There are recurrence, and of course, there are new onset ones. There is a lot of other comorbidities like COPD, smoking, their exposure, prolonged exposure to environmental pollution, and of course, their physical impairment. It's an heterogeneous group of asthma, of which the issue here is not that there is a heterogeneous group. The issue here is that they also can be allergic. And many times their allergic asthma is dismissed in their process of looking at everything else. Allergy is sort of forgotten. So main thing here is to see if allergy is a component that is contributing to their overall asthma, recognize the phenotype. If there are two things, also consider the comorbidities. And if there is allergy, even here, you can make a very, very significant difference to them if you treat the allergy in the correct way. Because of multiple comorbidities, all the studies show very variable prognosis to treatment. But I think if you look at allergy per se, you will have a good outcome. But for that, we need far more studies which look at this in particular and give us the results. The other and possibly the most prevalent allergic disease across all ages, and especially the adults, is allergic rhinitis. Nowadays, we are seeing allergic rhinitis in younger and younger children. We used to previously say that, you need to have a couple of seasons of sensitization before a child would develop pollen allergy. But even that we are seeing in very young children these days. But allergic rhinitis does start early but peaks in young adults. There is a considerable disease in the child as well as the elderly that has to be kept in mind. causes of allergic rhinitis will and can vary according to age. And the younger population seems to be more sensitized to the indoor allergens as opposite to the older or the elderly who seem to have outdoor allergens as well as the indoor allergens, if at all you want to take it that way. The differential diagnosis increases with age. Hence, a very careful history and assessment becomes all the more important as the age progresses. This chart shows you the prevalence of allergic rhinitis and the cause for it. Not the prevalence, but the cause for allergic rhinitis and across the ages. So if you look at it, the center is when they are 0 years and then 10, 20, so on. That's the age. And where the pointer goes at that particular circle is where the peak or the maximum prevalence of allergic rhinitis is. This is the green one is that of allergic rhinitis, and the blue is that of non-allergic rhinitis. As you can see, as they get older, non-allergic rhinitis also is quite considerably high and can be a significant differential and has to be considered as when you're taking history. And if you see, though when they're young, it is more of a dust mite and cold air and other sort of allergens which cause allergic rhinitis. As they age further, it becomes pollens that seem to take the front seat. There are not as many studies, though, which look at allergic rhinitis treatment in adults and in a proper way. And I think that would be something that would be really essential and helpful in us deciding how to treat our elderly population who have not just allergic rhinitis, a combination of rhinitis also. So, allergic rhinitis across the ages, you have very high prevalence in children and adults and adolescents. There is prevalence of allergic rhinitis which decreases in the older adults, but they have overall the rhinitis is still very common and quite significant. The challenge here is to tease out those people who do have allergic rhinitis and help improve their quality of life by treatment. The primary symptom in children is more cold and all the other signs that we frequently talk about, like allergic salute or ear infections. In adults, it is more an impact on their work and school performance and overall quality of life. In older adults, it is less pronounced. The itching, the sneezing is less pronounced, but it is more persistent postnasal drip, congestion, and dryness of the nose. Associate conditions are much more in the older adults or the elderly than in the other two groups. And diagnosis is far more complex with the older adults, specifically because in the younger adults and in children, when you do allergy testing with the skin prick test or specific IgE, you can get a good, reliable result, which is not so often seen in the elderly because their overall IgE may be normal, but their specific IgE levels are much lower, and their skin prick test reaction also is not as good as it probably should have been had they been younger. So the treatment approach also is similar in all. However, as they grow older, you have to take into account the polypharmacy. Usually elderly are on many more medications than the younger ones, and their caution regarding drug interactions and side effects is very important. When you look at the children and the adolescents or the adults, it is actually an excellent condition to treat with good allergen avoidance, antihistamines, and nasal spray. You get very good control, and with the appropriate allergen immunotherapy, the outcome is quite remarkable and makes a huge difference to the quality of life of these patients. Closely related to allergic rhinitis is allergic conjunctivitis. This is predominantly thought to be a disease of children and young adults. You can have simple allergic conjunctivitis, which is usually associated with rhinitis. This is acute, can be seasonal or perennial, and it comes and goes and doesn't cause too much of an issue. And it is usually, treated, responds very well to treatment. The ones that do cause problems are vernal keratoconjunctivitis and atopic keratoconjunctivitis. Vernal keratoconjunctivitis is again a disease of childhood, which is usually okay and resolves in adolescence. It can cause a lot of grief and a lot of problem while it is there. And if it is treated well, fantastic. But if it is untreated, both atopic keratoconjunctivitis, which can occur at any age, and vernal keratoconjunctivitis can be sight-threatening. So important conditions. So across the ages, or at least if we look at younger adults and elderly adults, if you look at the different allergic diseases, this is what we find. But now we come at diagnostic challenges. History. In the younger ones, in the very young ones, it is hard because you need to really tease out all the history. And then the slightly older child to adolescent and adults, if you are persistent, you can get a fairly good history, which tells you what is going on. Coming to the elderly again, history becomes problem. Comorbidities and polypharmacy is a particular problem, especially in the adults and the older people. Then you come to skin prick test. Skin prick tests are great for the younger population and up to the young adults or even their 30s and 40s. But once you cross the 65, 70, with the change in skin texture and the skin change in the skin reactivity, as well as the decrease in specific IG, it is not as reliable as it probably would have been in an in a younger person. Pulmonary function tests, again, at the extremes of age, hard. It is less so now with the availability of FOT quite freely, but otherwise, actually being able to perform pulmonary function test in some of the elderly is quite hard. Oral food challenges are a big challenge in themselves if we look at the very young and the very old. In the very young, because they cannot tell you what is going on and what is happening, so you wouldn't want to do it in the very young child. You want a verbal child before you can do it. And in the very old, because they have a much higher chance of a masked sort of reaction and having severe anaphylaxis, which is much harder to treat. So food challenges in the extremes of age would be very, very careful. Treatment too is very much dependent on, of course, history as it would be in any allergic condition, but age plays a major role in how you decide what you're going to do. You also, of course, your clinical and diagnostic evaluation is going to be your foundation for this, and so are the comorbidities. Effect of disease on the quality of life is something which you would also take into account and hence decide whether you are going to go ahead with a certain form of treatment or not. And age does make a difference in your decision making here. One of the key questions which now crops up quite often is, should we consider allergen immunotherapy in the elderly or the older adults? What should determine our patient selection? Is it the age of the disease or age of the patient? These are questions which are cropping up. There is not a lot of scientific backing for it if you look at the current literature around, but I think this is something where we can actually make a difference with more studies and research done. As of today, I think in the current fitter elderly, we should have a good, you should look at it as a whole, and if there is nothing to contraindicate an immunotherapy, then the current thought process is that we should go ahead with it. Meaning, if they don't have any other contraindication, any comorbidity that should, would say that they cannot have immunotherapy, you should treat the person with immunotherapy as long as they otherwise qualify for it and not take age into consideration. So, summary, allergy is quite different across the ages. There are quite typical triggers and typical management considerations that we should do for different allergies, different ages and allergies. It is a journey. So early recognition, targeted care, and education at every stage can transform outcomes for these patients. Thank you. Thank you for your patient listening.
I think this was something which was like a masterpiece type of a session, which I saw, like starting from Mosam and then followed by Dr. Kunal and then Dr. Sunila. So you all presented, you can say like in a in a very coordinated fashion. The way you presented, like first Mosam took some two real cases, which I really liked. Actually, I was having this thought in my mind, but I was not knowing that how to put up that in the PowerPoint and how to put up that. But I think Mosam has done really brilliant job by taking, you can say, like a 360-degree turn in which he started with an adult lady, and then she went one step back to her childhood, and then one step forward to the next generation, and then the second lady, and what are the different factors. So in two cases, she combined genetic and environment whole together, which was really the need. And then I think Dr. Kunal has done really wonderful job in which he tried to explain so many things from the molecular level, which are, you can say, like so many questions, and he tried to take so many good examples. So I think this was really needed because usually immunology is considered to be a boring subject, but he tried to put some life into that. So which was really a good thing. And then everything together, combining together, I think like Dr. Sunila is just like a wonderful moderator. She has just, you can say, like curated each and everything soon, or I will say that she has woven each and everything in the clinical presentation, in the clinical context. To my understanding, I think this was something which you have actually summed up. Whatsoever we have taught in past 1 year, you have, I think, summed up everything in past 1.5 hours. So, which was a difficult task, but you have really done a very wonderful job. I must thank you all and I must congratulate you all. Thank you. So now I would like to request Dr. Sunila ma'am for taking the panel discussion, and
Yeah.
then we can discuss further.
Yes. Thank you, Dr. Neeraj. Thank you for giving us the opportunity. Let's go on to the panel. We'll actually see some real life cases now in the panel discussion. So I invite, can you see my screen? Yeah. Can you see my screen, sir?
Yes, it's visible.
Yes.
Yeah. So I invite to the panel discussion Dr. Kilana Raghu Chanakya, who is a ENT surgeon and allergy practitioner in Andhra Pradesh. He has done his post-graduation from Andhra Medical College and is also trained in allergy from Medtrain. He is currently working as an assistant professor at Geetham Institute of Medical Sciences at Visakhapatnam. Welcome, Dr. Raghu.
Thank you, ma'am.
And now Dr. Nandana Bala. Nandana is a senior consultant pediatrician and allergy asthma specialist in Bangalore. She trained, her specialist pediatric training was from London Deanery, and she also completed her allergy training from Imperial College London and continued to work as a consultant in the respiratory pediatric section of the Guy's and St. Thomas's Hospital. She is a faculty at national, international allergy courses and conferences, and has contributed to various national protocols and modules in the field of allergy. Dr. Nandana currently works as a consultant pediatrician and allergy asthma specialist at Rainbow Children's Hospital and Prudent Health Specialty Clinics in Bangalore. And last, and possibly one of the most accomplished person in the panel today, Dr. Neeraj, who is a senior consultant allergist and pediatric intensivist and sleep specialist at Sir Gangaram Hospital in Delhi. As you all know, he's a faculty at national and international allergy courses and has contributed hugely to national protocols, practice modules, books, and research in the field of allergy. He's the current president of the Pediatric Allergy Chapter of the Indian Academy of Pediatrics, and also the driving force behind the academic feast that we are having these days, online and offline. Welcome, Dr. Neeraj. Welcome, Dr. Nandana.
Thank you, ma'am.
Thank you.
So if we go right into the panel, we'll start with a case. It is somebody who presented, AB, presented with classical symptoms of mild persistent allergic rhinitis. He said it's an almost constant runny nose and nocturnal cough and exercise-induced cough. He has a very strong family history of atopy and asthma. He also has dry skin. They live in an urban dwelling right next to a lake. they have been restricting milk and citrus in their diet because they believe these to be allergic food. Dr. Nandana, I would like you to take this. I mean, I just wanted to see with this kind of a history, what would our approach be different at different ages? So if, say, the same child presented to you at 2 years, at 7 years, 26 years, or at 60 years, what are the different additional information you would want, and what would you maybe look for in examination that would help you decide? Over to you, Dr. Nandan.
Yeah, thank you so much, Dr. Sunila, Dr. Neeraj, and Dr. Raghu. It's an honor to be a part of this panel, and I must congratulate all of you for this excellent session we had so far. And I think you've set a very good background for what we're going to discuss in this panel. So, you've nicely covered how age depends, or rather determines how we approach allergy at various stages in the patient's life. So, for instance, if you could just go back one slide, Dr. Sunila.
Yeah, I am trying.
Yeah, anyway, so if we go through this history, you have this patient with mild persistent allergic rhinitis and nocturnal cough and exercise induced cough. So here it would be very important to know the duration of the symptoms, because how we decide to treat it and how we decide to progress with the treatment will determine what we do next also. So based on the duration of the symptoms. So for instance, if it's a 2.5 year old child, they've had a very limited time frame over there for their symptoms. As Dr. Sunila was mentioning earlier, unfortunately, we are seeing more and more young children develop symptoms of allergic rhinitis, and that's a very worrying trend. But I think that's how we're going to see in the future too, and we need to know how to deal with it. Whereas if I have a 7-year-old with the similar symptoms, so again, the duration becomes very important. So I want to know whether this is a new disease or whether this has been going on for a long period of time. And I want to know the progression of the symptoms, because that will decide whether I would want to consider this child for immunotherapy, along with the pharmacotherapy, of course, that we would do to optimize the medical symptoms. Now, at 26 years, again, the duration and the progression becomes really important. So we all know that, especially when we are considering a patient for allergen immunotherapy, apart from the standard pharmacotherapy, which we would do anyway, we want to see how old the disease is. So, one of the factors that we would see when we consider immunotherapy would be the age of the patient. And the other important factor is the age of the disease. So, for instance, 26 years, he's a young patient. But if the disease has been present for, let's say, more than 20 years, and there is evidence of structural changes, including tissue remodeling, for instance, there is, evidence of like a fixed airway obstruction, which is unlikely in a 26-year-old, then, I would reconsider my decision on allergen immunotherapy. Whereas if it's a patient who's 26 years old with a 2-year history of allergy, for instance, then I would say that if the sensitization pattern as well as the allergy test are consistent with, an allergy which can be treated with allergen immunotherapy, I would definitely counsel this patient for allergen immunotherapy. And at 60 years, again, it depends on the age of the disease. So as Dr. Sunila rightly said not so long ago, that even in an older patient, if the disease is young, and if we feel that the treatment is going to actually improve the patient's quality of life and help us with the disease management, then apart from standard pharmacotherapy, definitely one would want to think about allergen immunotherapy. Of course, given that everything else is fulfilled, like for instance, if the asthma is well controlled and if the FEV1 criteria is fulfilled at more than 70%, etc. So there are so many factors that I would want to tie in. And my decision about the approach would definitely be dependent upon the age of the patient as well as the age of the disease, more importantly also.
Ma'am, can I ask you one question?
Yes, Dr.
So,
Neeraj.
like if, for an example, in this case, let's take two patients. One is at like 26-year-old, 30-year-old. Another one is 60, 65-year-old. And in both cases, the disease is 2-year-old. Let's assume that in both cases, the disease is 2-year-old. That means that factor is now out. The disease is 2-year-old only. But one patient, the chronological age is somewhere around 25, 30. Another patient, the chronological age is 60, 65. So what do you say about the efficacy of allergen immunotherapy in either of the patients, especially after listening to Dr. Kunal's talk, when the immunological mechanisms by themselves are going haywire in 60, 65, or 70? So, what do you think about that?
Yes, that's a very, very valid point, actually. So, when we would approach, so the 26-year-old is relatively, straightforward. With the young disease of 2 years of age, provided, everything else, all the prerequisites for immunotherapy that we would consider are fulfilled, then, that patient would be considered as an ideal candidate for immunotherapy. So, when we talk of indications for immunotherapy, we always talk about who is the ideal candidate. The 60-year-old, certainly, I would say, would be a less than ideal candidate. So the traditional thinking was that generally in elderly, particularly more than 60 years, we would not actually actively consider allergen immunotherapy. But the current consensus or the current thoughts are moving away from that. So, one would assess the general health of the 60-year-old patient, and considering that the patient has a young disease, if we find that the patient has an active lifestyle and the quality of life is being impaired by the presence of the respiratory allergy, and we are able to control the disease well with pharmacotherapy, then although this patient is a less than ideal candidate for immunotherapy, I think we do need to offer the option to the patient. And then ultimately it is a joint decision taken by the patient and the treating physician with the appropriate informed consent. I think that would be more crucial in this patient.
Thank you, Dr. Nandana. I think I just came forward a little bit. I just wanted to put up this in between to just show that it is a mix rather than just a mono sensitization. So that will also have an implication on whether you decide and for immunotherapy or not, and which immunotherapy. So this is not a straightforward monosensitized person. This is an actual report of the person that we are discussing. And as you see in this patient, there is also a little side skin prick test for milk, banana, and citrus. Do you want to
Yes.
say about it?
Yes. Yeah. So first of all, just want to say that when we talk about ideal candidate for immunotherapy, so a monosensitized patient or somebody with very few sensitizations generally is a better candidate. Whereas somebody who is polysensitized, it's not that we cannot do immunotherapy. It's just that the response that we may see may not be as good as in somebody who is monosensitized or has few sensitizations, rather than somebody who has this many sensitizations. Okay. But even then, we have to remember that it's not only sensitization, it's actually the clinical translation into allergy that actually we are trying to determine with the correlation with the clinical symptoms. So patient may be polysensitized, but may not be polyallergic. So there, a careful history and sometimes taking our time, taking a second history, taking a third or fourth history over a period of time may help us determine this better. So your little side column about the sensitization to these foods. See, as we all know, generally we would not test for these things in a patient with predominant respiratory allergies. But here, this patient from the history looks like was unnecessarily avoiding these foods out of fear or out of misinformation. And sometimes we do the allergy tests for the foods just to prove to the patient that it's not, the patient is not sensitized and there is no clinical correlation, so there is no allergy, and hence the patient can safely take these foods.
Thank you. Thank you, Dr. Nandana. moving on. So here we have the different decisions at the different ages that we would take. Moving on to the next, this was actually a 2-year-old's skin prick test, and he had a surprisingly high number of pollen polysensitization, and they were living right across the lake in Bangalore itself. So, you know, this is not a made up skin prick test. It is a true skin prick test for a 2-year-old, which shows how early polysensitization is now occurring. So now we come with a different scenario altogether. A 48-year-old who has had ongoing symptoms of nose block and fatigue for 15 years. He's got perennial symptoms. He does not have seasonal or diurnal variations. Previously has had skin prick test done and also was tested for allergy, I think a specific IgE prior to the FES surgery that he underwent, and both showed no sensitization. He underwent FES surgery actually twice, which I have not put here. He did have brief symptom relief post-surgery, but then it all came back. But then he had to go transferred outside India. When he was outside India, again, his symptoms got better, but flared up as he came back. He now has started having a little bit of cough and wheeze intermittently. And on examination, there is bilateral turbinate hypertrophy, postnasal drip. There are no polyps, and his ear and chest examination is normal. Dr. Raghu, would you like to sort of talk to us through as to what this might be and how to progress or proceed further in this scenario?
Yes, ma'am. First of all, my sincere apologies for everyone because I'm having a very bad laryngitis. So, and I would like to thank Sunila ma'am, Neeraj sir, and Nandana ma'am, and Indian Academy of Pediatrics Allergy chapter for having me in today's discussion. Ma'am, can we go to the history once, previous slide? So here in this slide, the patient is having a continuous nose block for the past 15 years. So which was telling us there was definitely a structural abnormality or an anatomical abnormality for the patient. And patient had an SPT and allergy, but we don't have the proper details of for what allergens the patient was tested to. And we don't have the exact history because in our allergy practice, history is the most important component that we need to. And patient underwent FES, maybe probably I expect he might have also got his deviated nasal septum also done. So
It
maybe
was
because
done for aeroallergens. I didn't put
allergens.
aeroallergens.
Okay, ma'am.
Everything was negative at that point.
Okay, ma'am. So he might also have got a deviated nasal septum correction also done. So that is why he might be having a symptom relief post surgery. So in the next slide, it was clearly mentioned that his nasal symptoms were flared up once he returned back to India. So definitely, it is showing a little bit of allergic history because we always know that the diesel exhaust particles or the particulate matter varies from developed countries to developing countries or from our country. So it might have definitely have an impact on the allergenicity if the patient is sensitized to any one of the known allergens. And the bilateral turbinate hypertrophy and all explains the consistent symptoms the patient is having. Here again, the postnasal drip again tells us that patient might be having an ongoing inflammatory disease in his nose. That is why he's having that constant postnasal drip. So as there were no polyps, so it comes under the chronic rhinosinusitis without nasal polyposis kind of phenotype. So maybe in this patient, I'll try to take the history again, and I will do a skin prick test or an uh, a immunocap, so that I'll see the sensitization patterns, and I'll do a second history. Uh, okay. So the repeat SPT showed sensitization to cockroach, which they might have missed in the previous skin testing. So we all know that cockroach sensitization, and if it is correlating to the history, then definitely it is a strong sensitizer, cockroach. So definitely in this patient, first I'll ask him uh, to start on the preventive measures, like what we do, that integrated pest management. So first we'll ask him, like in Indian settings, in a lot of patients, when we ask when there is cockroach in the home or not, many of the people deny considering this or translating this as something that is related to their hygiene practices, but it's not the case, as we are living in environment in the apartmental kind of a setup. So even one cockroach in the home itself shows that or says that there are multiple or n number of cockroaches in the pipes and all. So first I'll ask the patient to have a source control. So yeah, so and strict avoidance measures to be started, and I'll counsel the patient for these preventive measures, and also I'll explain him what exactly is happening with him, and I'll ask him whether post surgery he has been doing that intranasal corticosteroids, because this is one of the mainstay of treatment to control his symptoms. And nasal wash is definitely has to be done in all the cases of allergic rhinitis, because that will lessen the allergen burden, so that patient will have a relatively symptom free period. So if at all, if these things have been correctly practicing by the patient, and if it is correctly monitored, and if we can see the complaints of the patient, definitely his quality of life will be improved. In this case, we'll strictly ask the patient for no immunotherapy, because the avoidance measures are much more beneficial for the patient when compared with the immunotherapy.
Yes, thank you, Dr. Raghu. That was very comprehensively said. Yes, this was again, he was not started on immunotherapy, and he did very well with the treatment and avoidance, and is continuing to have doing well and much improved quality of life. Thank you. Moving on. So now it is somebody who's again a 35-year-old with asthma. He has no other atopic symptoms. However, he gives a history that he has been avoiding milk, or he avoided milk. The history is that he never actually liked milk from the beginning, but his mom forced him to have it, and he sometimes vomited and reports feeling uneasy, bloated, and sometimes even had diarrhea. So he thought that he had milk intolerance or lactose intolerance. So he tried to avoid milk as much as possible. He accidentally inadvertently had a milk containing sweet in a office party, and within 10 to 15 minutes, he had rashes all over his body and angioedema. He did not have any breathing difficulty, but he went to ER, wherein unfortunately all he got was IV antihistamine rather than anything else. He was monitored for a couple of hours and then sent home. He was then seen by the allergy specialist, and a specific IG to milk was done, which showed 4 kilounit allergens per liter, and a SPT to milk showed a wheal of 9 millimeter with erythema and itching. He underwent CRD2, which is component resolved diagnostics, and that came positive for BOS-D8. Dr. Neeraj, would you say what might have happened here and what is possibly the best way forward for this 35-year-old male? Dr. Neeraj, you are on mute.
Ma'am, if we first see the initial two statements, that means like an adult who is having a known case of asthma and never liked milk, and then the past history, which is probably suggestive of some sort of more intolerance rather than the actual allergy. So the initial two statements, he is actually not fitting with a type 1 hypersensitivity to milk or IgE mediated hypersensitivity. But now the third statement, it is very characteristic that within 10 to 15 minutes of milk exposure in a sweet, then the reaction happened. So that means it seems to be IgE mediated manifestation, and then he required to be presented to ER. And then with this history, if the specific IgE, which was also high, so I would consider that yes, this particular patient is having definitely IgE mediated milk protein allergy. And obviously, the skin prick test was done after this episode, probably around 3 to 4 weeks after this episode, and the wheal is also positive. And the component result diagnostic is also suggestive that BOSH-T8 means casein. Casein means heat resistant, the component of the milk, which is positive. That is, once again, there are more chances of severe reaction. So I would like to consider here with this possibility that IgE mediated milk allergy in this particular gentleman. Now, the important thing is that usually we consider that milk allergy is more common in the younger age group, somewhere in the 2 year, 3 year, 4 year. And by the time, somewhere around 5 or 6 year, nearly 80% outgrew. But yes, sometimes even till 16 years, nearly 90-95% outgrew, but there are 5 or 7% which can actually stay for till adulthood. So he's one of them. By 35 also, he's reacting to milk. So now it is very less likely, almost not likely, that he will outgrow from this particular problem.
Thank you. Thank you, Dr. Neeraj. So yes, it is allergy, not intolerance. It was probably intolerance to begin with. At some point, he has, switched and it has become IG-mediated milk allergy. And as Dr. Neeraj rightly said, because of his late onset and its persistence, it is possibly going to remain as is, and he should probably continue to avoid milk completely. And that is what he's doing. But he's much happier because he's now got a clear diagnosis, and now he can actually very clearly say, he cannot have milk rather than what he was doing before. So we are going on to another food allergy. Sorry, this is I'm sorry. This is a 50-year-old who again is a marathon runner, very fit 50-year-old who has been running marathons for quite a few years now. He presented with a history that he was running a marathon outside India, had a sudden onset of hives, which progressed on to full-blown anaphylaxis during a marathon event. At that point, he was treated for anaphylaxis quite appropriately and responded and recovered well. And had sort of, this was a few weeks after that the event had happened. But he was not atopic. At least he didn't give history of atopy, but he did have occasional nose block that he didn't really consider much at all. He did have, digging into the history, he did have a rap on the street side just before he started running. And that was the only thing that was unusual for him, other than his usual routine that he normally does, which is have a banana before he goes on his runs. And but he is somebody who is regularly eating all food. He has no food allergy whatsoever. And this was the history. Dr. Neeraj, would you want to take
So,
this?
like in this case, what we understand is that there is something, most probably the exercise, which has actually triggered his severe clinical reaction or the allergic reaction, and which landed up into anaphylaxis. Now, because he is also a marathon runner, so he is actually used to the exercise. So there is something else which is also happening along with the exercise here. So by taking a good, careful history, as you rightly mentioned, that there was some history that he took some rap, which was an extraordinary thing, which he's not used to do that earlier on before the exercise. So it seems to be something like a food dependent exercise induced anaphylaxis. And I think in the previous talk, Dr. Kunal, I think, mentioned about this, that whenever somebody who is tolerating a particular food with an intact epithelium, but because of certain conditions, because of certain situations, it might be possible that the gut becomes more leaky. And at that particular time, the same amount of, or the same quantity or the quality of food is now going as an intact protein inside the gut, getting absorbed, and now it is behaving like allergen. So exercise is one such thing in which usually what happens, that the gut becomes more leaky at that particular time, and if the food item which is there, then the intact protein can go inside. And here you are showing that this CRD is positive for omega-5 gliadin. So it is possible that this omega-5 gliadin is actually along with the exercise, when the two are coming in together, within a, you can say, like a short period span of time, somewhere around 2 to 4 hours within that time period, then they are actually aggravating the symptoms. So one thing which I would like to say, but in fact two things. So these type of patients, many a times it happen that you do the whole wheat allergen extract testing. That could be the skin prick test or the specific IG, and the results might be negative because they might not be representing adequately the omega-5 gliadin. So at that particular time, in a highly suspected case, you have to really test for the component, and then only you have to see. So this is one. The second thing is that the diagnostic test will be something like, in the laboratory, you have to really do the food testing, food challenge. The challenge will be negative. You need to see the exercise challenge. The challenge will be negative. And then you need to do food and exercise challenge in subsequent edition. And at that time also, it is only 70% positive, but 30% cases, it might also be negative, because it is not only food and exercise. There is another term which is called as AFIFA. So FDEIA, the new term is called as AFIFA, which is augmentation factor induced food allergy. So it is not only the exercise, there are so many other factors which are also producing similar effects That could be some sort of NSAID, that could be stress, that could be even sudden change in the environment, temperature. So it is possible that not only the exercise, there might be something else which is also contributing a little bit. We might not be able to reciprocate the same conditions in the laboratory, and that is why the test is coming negative. But clinically, this particular patient is fitting in food-dependent exercise-induced anaphylaxis.
Thank you, Dr. Neeraj. That was very helpful. Yes, he does, and he continues to run. He now carries an EpiPen though, and he continues to run. And he's had wheat-containing food before and continues to have it without any issue. But he's very careful. He's a very, compliant patient. He's very careful that he doesn't do any exercise around the time that he's consumed wheat. He's actually very careful, and he's okay. So I think we are now running short of time. So I'm going to stop it there. Thank you all members of the panel, and Dr. Kunal and Dr. Mosam. Thank you very much for accepting the invitation for presenting today and talking to us. And thank you, Dr. Neeraj and IAP and Allergy Chapter for giving us an opportunity to do this and speak to you.
I would like to thank Sunila ma'am for such a wonderful, I think, you can say like webinar, and such a wonderful speaker, such a wonderful, you can say like everything which she has pulled together, not only the speaker, the content and the thought process which she brought together today. So which has actually, you can say like, came out with a something new concept, something different concept, that why the elderly also can be, you can say like allergic, why elderly can also be subjected to immunotherapy, what are the limitations, what are the pros and cons of different testing, different history, same type of presentation, different age groups, different type of history. A person who is having a family history still not developing allergy, a person who is not having a family history still developing allergies. So lot different things which have been discussed today, and all the people including Dr. Raghu, Dr. Nandana ma'am, and I think Dr. Kunal and earlier Dr. Mosam complemented each and everything so well, so well. So thank you so much. Thank you for doing this for us.